Well, welcome, Dr. Pisters. I'm so happy to get to talk with you today. Thank you so much for being with us.
Meg, it's great to be with you.
So let's start, kind of with broad strokes, just thinking about the state of cancer care and diagnosis right now. Can you put into perspective the kinds of strides that have been made maybe over the past few years to decade in terms of how we treat and detect and diagnose cancer?
That's a great jumping off point for us to really think about the evolution of cancer therapeutics and diagnostics. I think that from our standpoint, and certainly as you know from your work, one of the biggest advances has been the advent of immuno-oncology and the advent of checkpoint inhibitors and the impact that that's had in a number of cancers. I think that's best exemplified, of course, by melanoma, where we've seen dramatic increases in survival from 3% for patients with stage 4 disease to upwards of 60% today. One of the most important things for us to keep in mind and perhaps to talk about is that those gains have been uneven, and a lot of the work that we need to do now is understanding what really is driving this from a biologic standpoint and how to target new interventions that help non-responders.
Yeah, maybe tell us about that, because I think people hear about these amazing drugs like Keytruda and Opdivo and, all the drugs that are in this sort of immunotherapy area, and they think, wow, like there are really amazing strides for cancer, but there are patients for whom they aren't applicable yet. Where is the research on that? How long do you think it will take us to kind of chip away at the areas where immunotherapy doesn't yet reach?
Well, we're working hard at that right now, and we realize that when we have a population of patients enrolled in a clinical trial and they divide themselves up into those that benefit through response and those who are unfortunately not in a position to respond meaningfully or durably to the treatment, we have opportunities to uncover the scientific reasons behind that. And our work really to harvest a series of tissues and body fluids and to understand the science that drives non-response is clearly, unequivocally, the ways in which we can drive new drug discovery and new treatments for those patients. So we're working really just as hard with the non-responding group and the research around that as we are in celebrating with the responders who are overjoyed with the new responses and with the durability of some of those responses, which, as you know, have reached out to decades for some patients with immunotherapy now.
Yeah, it's really incredible. Maybe walk us through some of the technologies that you're most excited about that you see really helping us kind of get to that next level.
Well, certainly one of the big advances related to immuno-oncology is cell therapy. And as you know, that's not using a drug. It's certainly not using any form of standard treatment. It's not an injectable. It's not an oral agent. But it's re-engineered T cells or other components of the immune system that can now be used in a variety of targeted ways. As we look at CAR T therapy, for example, we just crossed over the threshold of doing our 1,000th CAR T treatment here at MD Anderson. That's a milestone that's given us tremendous amounts of data, benefited many patients, and helped us to understand where we need to apply effort and attention right now. As you know, these are game-changing treatments for the patients who receive them, but they're associated at times with significant risks for toxicity. The durability of response can be an issue for some patients, and there are issues related to the cost of treatment and its scalability. So I think now what we need to think about is how can we extend those gains that have been seen primarily in patients with hematologic malignancies to solid tumors, and how can we reduce the toxicity of treatment, perhaps by using other components of the immune system innovatively in the future.
Yeah, and one of the things that has been really interesting with CAR T, and just to explain to the audience, I'm sure a lot of folks know, but this is such an interesting technology because you're actually taking a patient's own cells out and kind of beefing them up to better fight cancer and then returning them. So the manufacturing process here is so important, and we've seen some companies actually run into roadblocks and not be able to supply enough of the drugs because it is such an onerous manufacturing process for each individual patient. You guys recently struck a partnership with this company called Resilience to actually do some of this manufacturing. Tell me about that partnership and what you're doing.
Well, it's very important that we think about the complexity of the supply chain that you were describing. When you're using the patient's own white cells or autologous strategies, And those cells are then being shipped out to another location in another state to be genetically modified, clonally expanded, and then shipped back. There's a complex supply chain that adds logistical elements to it. It adds time. It adds complexity. And when you add to it the sterility issues associated with the supply chain, you can see how this drives up cost and complexity over time. As we think about that, one of the most important things that we want to think about is how we can move more directly through partnership into manufacturing. And that's what the Resilience Partnership is really all about. It brings our abilities to scale up beyond our GMP facility and into a manufacturing partnership so that we can do this for ourselves and our own investigators, as well as for small biotech companies that don't have the resources to do this.
That's totally fascinating. I think one area that people are very interested in is this area of NK cells. And you've got this fantastic researcher, Dr. Katie Rezvani, who I got to speak with last year about her work. Maybe tell us about this area, what sort of newness it brings to the way we approach cancer.
Well, Dr. Rezvani's work and our work with CAR-NK treatment utilizes a different component of the immune system, the natural killer cell. Some people, Meg, as you know, refer to the T cell as the soldier of the immune system, and we might think of the NK cell as the cruise missile. It's very effective and has immunologic advantages in the sense that it doesn't cause the graft versus host disease that we see in patients who receive standard CAR-T therapy. That creates some immunologic advantages, and when we can really derive those NK cells from cord blood, from umbilical cord blood samples, which are a generous source of hematologic cells and stem cells, and grow up the NK cells, it creates a totally different off-the-shelf solution that is free of some of the toxicity associated with CAR-T therapy. And as you know, we've seen very encouraging responses, primarily in hematologic malignancies, and looking at how we can expand those responses over time and extend that possibility to solid tumors, which still remains really a target for us in the future. How can we take these approaches for cell therapy into solid tumors on a larger and more effective scale?
One of the things you mentioned, of course, is how many patients that you see and treat there, and that gives you a lot of samples and a lot of data. So how are you using that data in a sort of artificial intelligence mind frame to try to improve the research you do and ultimately perhaps, the patient outcomes?
Well, that's such an excellent question. And when you look right now at where we sit, and just within the last few months when we have ChatGPT and Bard right on the horizon, and we're in an era that might be the same as the introduction of the calculator, we can really see dramatic changes that we are scratching the surface of right now. When we look at the volume of data that's being generated through routine patient care, and you look at, for example, at MD Anderson, we saw 175,000 patients last year with 400 different cancer types or subtypes. And each one of those patients, through their clinical care over the course of the year, generates 2 gigabytes of data. There's no human being that's capable of analyzing 2 gigabytes of data coming from a single patient. And we've got to use technologies that allow us to do that. We're making a big push in data science here at MD Anderson, enabling us to really understand that. I say all the time that the clues to unlock the mysteries of cancer are hiding in our freezers, where we have samples from patients and their tumors, and they're hiding on our servers. And we've got to bring the right talent to MD Anderson, organize the data, and then interrogate the data in very, very important ways that allow us to gain insights into pathology, imaging, operations, quality, safety. It's a limitless set of possibilities that we see right now with the use of AI technologies.
It's fascinating. And we're talking about all of these really, high-tech things, from, using AI to improve research to the kinds of high-tech, technology that you're actually doing in terms of the research. Let's talk about patient access and affordability. How would you characterize this status of, cancer care in terms of access and affordability in the United States, right at this moment?
Well, I think as a country, this is an area where we have to put a lot of effort and attention. And at the moment, for reasons related to the linkage of patient insurance to employment, we have uneven access to oncology care, screening, and prevention strategies overall. This is something that I know is a point of concern at multiple levels within government and a focus of our efforts in health policy as we think about how can we really improve access over time, how can we reduce the cost of cancer care given the cost of innovation, and how can we create a much more even experience that elevates the quality and outcomes for patients across the whole country.